Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
And today, we have some thrilling news for you.
That's right. Get ready to mark your calendars because we're bringing the conversation to you live and direct.
Join us at the highly anticipated Primary Care 24 event on Wednesday, May 22nd, where we'll be hosting a special live recording of our podcast.
It's going to be an absolute blast, filled with insightful discussions and special guests.
Whether you're a healthcare professional, a policy wonk, or just someone who cares about the future of primary care, this event is for you.
So grab your headphones, your favorite beverage, and head over to primarycareforamerica.org/primarycare24, or just click on the link in the show notes to register for the event.
Don't miss out on this unique opportunity to be part of the conversation shaping the future of healthcare. See you there.
Register now at primarycareforamerica.org/primarycare24. Faisel and I can't wait to see you there. Today, we're talking to Dr. Robert Pearl, physician, leader, and author about ChatGPT MD, AI-empowered medicine. Let's dive right in.
Hello, Dr. Dan.
Hey, Faisel. It's good to be with you.
It is great to be with you. And look who we have here. We've got Dr. Robbie Pearl. It's so good to see you.
Hey, Faisel. It's great to be back with you and Dr. Dan.
The first book that I was handed by Gordon Chen was Dr. Robbie Pearl's book, Mistreated. And that just changed my entire life. I mean, I think about my mindset from being a community health doctor, seeing 1 to 2 patients, the typical community health world, not even 2 visits per patient per year, coming to Chen Med, where the patients are seen monthly and they have an intimate relationship. And the book that drove a lot of my mindset and several hundred of our Chen Med doctors' mindset was your book, Mistreated.
I appreciate that very much. And actually, that book and my second one ties in with now my newest book, ChatGPT MD. I'm sure we'll talk about that this morning.
Yeah, I'd love to get into it. Dr. Dan, you and I, we talk all the time about, even while we're seeing patients, in between seeing patients, we're always talking about the basics of the doctor-patient relationship. Several times a week, we'll have a rough day. It happens to all of us who are out there seeing patients. Nothing ever works the way it's supposed to. It's not always that, you placed a referral and guaranteed it. There's always something where there's a human being involved where things fall through. And if you have a model that's a relationship-based model where you're working with a consistent team, we can help overcome the doctor's shortcomings, the different members of the team's shortcomings. But here you've got this book and you're saying, well, you can amplify those relationships. The technology can be an extension to the doctor-patient relationship if we just embraced it. And I don't know, I look at the way my 6-year-old is growing up with my home is a completely smart home with Alexa and all that stuff, all the lights and the music, whatever things they want. And for him, it's made his life better. I look at his life, I don't view all this technology and everything being a barrier to his childhood or his experience. I think it's a wonderful experience. But, maybe we could start off with this question. Dr. Pearl, why do you think so many of us in healthcare, me included, are so resistant to embracing some of these very simple, just what the ideas that you talk about are very simple. You don't need to stress yourself as a clinician, especially who's leading a team, with a lot of the frivolous things. We know this and we complain about it, but why are we so resistant to embrace some of the positive changes?
I would like to start even one step before that, which is the challenges that doctors have today, because I think we can put into that context the resistance to technology, at least the kind of technology we're discussing right now. It's interesting. You and I have talked a lot about burnout across the years and ways to try to improve it, the problems that exist. And I came across a fascinating study done by the independent, highly regarded Commonwealth Fund. And it looked at burnout. I'm going to speak a lot today to primary care because that's a major audience listening into this show. I looked at primary care burnout in the 9 most industrialized, wealthy countries of the world. Now, I would have told you, based upon everything that I had seen, that the United States would be far and away the worst. I don't know what you might have thought. Of the 9 countries, we were right in the middle. Of the 10 countries, the other 9 others, we were actually better than 5 and worse than 4. And I said to myself, how is that possible? And the answer to me is that the common problem in medicine today around the world, because it doesn't matter whether you're in the US with our really broken reimbursement insurance system or in another nation with a government-funded program, the numbers are the same. And to me, it's really the epidemic of chronic disease. Way back when you might have been training, the majority of patients who came to you had acute problems. You diagnosed appendicitis, pneumonia, a heart attack. They might have required some intense treatment, but when they were done, there was no need to see them again unless they developed a complication as a result of that. For heart attack, you probably saw them again, but appendicitis or pneumonia, you didn't. And then what do we see now? Now we see a major problem with chronic disease, diabetes, hypertension, asthma. And what's the problem? If I come to you as a patient and I have diabetes, you now will have to see me 4 times a year for the rest of my life. That's a huge amount, particularly when you think that 60% of all Americans have a chronic disease, 75% of people on Medicare have 2 or more chronic diseases. And I think that that's the fundamental part. And right now, clinicians are running so fast, they're out of breath, they're on a treadmill that's going ever faster. And anything else you ask them about, their first reaction is no. Not because in some way they're negative, problematic, left in the past, Luddites, whatever you want to say. No, they're just exhausted. And so I think it's that fatigue and exhaustion that needs to be addressed. And I think it erodes a doctor-patient relationship. You don't have the time to delve into the deeper levels of the problem. By the time you find out the acute problem, you figure out a prescription for medication, maybe you touch on 1 or 2 chronic diseases, you are done. Time to move on to the next patient. I don't know if you saw this study. It said that the typical primary care physician would need, you ready? 27 hours a day to do all the things that are necessary. Generative AI, ChatGPT will not solve that. And for your listeners, I do want to stress the fact that the book ChatGPT MD is subtitled How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine. They've lost that control. And I also want to point out, as I did in my previous books, that all profits go to Doctors Without Borders.
Robbie, you bring up a great point there. And I was just thinking while you were talking about that, I remember as a medical student resident in the Cecil's internal medicine textbook, which was, the huge doorstop, probably, 1,500 pages, 2,000 pages. I don't know the exact number, but there was probably one chapter of maybe 5 pages that talked about the doctor-patient relationship. And we all were rewarded on rounds by the amount of, not trivia, but the details we could remember about different disease processes. But don't you think that tools like ChatGPT and AI will allow us to focus much more about how to build the relationships and help people make the decisions with the information that ChatGPT provides, rather than having to spend so much of our precious RAM in our head focused on the details of the different disease processes?
Well, the first thing I believe is that if clinicians embrace it and empower patients, that 20 to 30% of what we do in the office today could be done by the patient at home. And that's a huge leap. So people need to have data that shows it's reliable and it's safe and other pieces. But at least we can discuss in detail based upon the research that I've done. That is the opportunity that exists. But I want to add a second piece to it, which is that unlike acute disease, chronic disease is with you every single day. And how do we manage that in the typical primary care physician's practice? You see the patient every 3 or 4 months, and in between, you know nothing. You have no idea what's really going on. The patient's not sure what to do, and yet we know that these problems exist continually. And if we could intervene sooner, we could better manage them. If we could better manage them, we could reduce its complications. And just try to imagine what would happen in medicine if we could eliminate 30% of heart attacks, strokes, cancer, kidney failure, peripheral amputations. You can go down the list of things that chronic disease ends up producing. So if you think about that, what could we do? And we have wearable devices. They're very reliable. They're very small, very reliable. Blood pressure, pulse, blood oxygen, blood glucose. You know the whole range of them that exist. They've been well proven, well documented. And how much do we use in medicine today? Next to nothing. Now, why? Here's a reliable device for a chronic disease that we'd want to manage. We're taking care of hypertension. We want to know what the blood pressure is. So why don't we use this all the time? Because the patient can't use it. 100 blood pressure readings, 80 are normal, 13 are abnormal, 7 are borderline. What do they do? What's going on? Does the 80 normal mean they're doing okay? Or the 13 abnormal mean they're problematic? What should they do with it? This is a simple problem for a generative AI tool to be able to do, particularly after doctors are able to put into the generative AI system through what's called GPTs, plugins they used to be called, exactly the limits and the expectations that they personally think is important, when they want to be notified, when the patient's okay, and something in the middle about what the patient should do, if it still is ambiguous. Now you're having a much more continuous relationship. You're not on the phone with the person. Do you want the patient coming to your office with 100 printouts of blood pressure? No. Do you want it in your electronic health record? No. Here's a solution that both makes care become continuous, takes care of a lot of the problems. So when the patient comes back, you know how they're doing. In fact, if there's a problem after 1 month, the blood pressure hasn't responded as you thought, you can set up a quick telemedicine visit. But if it is normal, then there's no reason to come back for that particular problem. This is the transition. Right now, we're stuck. We can't do anything, so it's episodic. And then, by the way, if 20 to 30% of the things we now do, which is going to be often related to the electronic health record and to billing and claims, was done without the patient in the office, now we have more time to engage in that conversation. It's that human-to-human contact. We call it the doctor-patient relationship, but it can't happen in the typical 17-minute visit, and it can't happen when you see someone intermittently for a problem that they have every day. In ChenMed, you were very able to accomplish all this because you had a better model. We could talk a lot about what needs to be taken from that model for all of American medicine, because there's a huge amount. As you know, I'm a massive supporter of the work that ChenMed has accomplished. But I think the key point right now is going to be, how do we move from the broken, fragmented fee-for-service of the past, intermittent, uncoordinated effort of care, to the kind of work that you did in ChenMed, but how do we do it for doctors across all communities of the United States? And that's where I saw ChatGPT as being a potential solution. And I say ChatGPT MD, it's just as true for Gemini, it's just as true for Claude. It's all of the generative AI tools that either are available now or will soon be.
And I was thinking about that, and I love playing with the different AI tools, but I can remember back in a previous life, I just wanted to set up a protocol in the office that if a patient called and wanted to, because when I started blood pressure medicine, my intention is they're going to stay on it until I stop it. And so if they called and they had been seen in the previous year and their last blood pressure reading was normal and they had normal renal function, then it would be okay for the nurse or whoever in the office to go ahead and call in an extra year's worth of refills on the medicine. And, if they're due for an appointment, set them up for an appointment. But I wouldn't have to take time out to go through that thought process because I could automate that algorithmically. And the compliance group was very adamant that they didn't want that to happen. So how are we going to get past compliance to allow, I guess it's the same as the driverless car, right? Who's responsible for the driverless car if there's an accident? Who's responsible? Even though AI is going to be much better at doing these rote tasks than humans, there's still going to be an error rate, even a very small error rate, and we're going to want to blame somebody for it.
You're raising a couple of key points. And again, I always like to start at the beginning and then try to answer your question about liability more towards the end. How do we do today in the United States? We manage hypertension between 55 and 60% of the time. We know we can do 90%. When I was a CEO in Kaiser Permanente, that's what we got. But we did it because we had a single medical group that all shared a common electronic health record, and we had a very formal structure in place. But of course, the US today would do poorly. How do we do in diabetes? Even worse. 1/3 of Americans with diabetes are under good control. Now, that is a pretty disturbing statistic when you think about that hypertension is the leading cause of strokes and that diabetes is the leading cause of kidney failure and a variety of other problems, peripheral amputation and cardiovascular disease. So we are doing poorly today. So the question I have is, can we do better? If the patient you put on a medication, a month later, the blood pressure hasn't responded appropriately, you don't know that. And if they call for a refill and the blood pressure is more problematic, you may not even know that then, but you don't have time to have patients calling into your office with all the results, because it's not just taking one blood pressure. We know that can vary by a myriad of factors. So that's where I think that the generative AI tool in the patient's home. And by the way, if you're telling the patient, we want you to cut back on salt, they're not quite sure how to do that. They know they shouldn't open the salt container, but they can put into the application information about a lower salt diet and get a shopping list and menus are the tools that are there. You tell them to do some exercise to help lose some weight. How do they begin? They can get that out of the same application. I think this is a more comprehensive, broad approach to medical management. And you're absolutely right. It's like the self-driving cars. Today we have 400,000 Americans who die from misdiagnoses. If this reduces it to 100,000, everyone's going to be critical. 100,000 people died. No, 300,000 people lived. And now you're raising the question about the liability. So I'll be publishing next week in Forbes exactly an article on this topic, consulting the nation's leading professor in the law school at Stanford about this question. And I think there's a variety of things about that. I think the first thing is it has to be tested. We have to make sure these applications work. And I tell everyone what exists today, GPT-4 or Claude or Gemini, isn't yet ready to be given the opportunity to work independently. You still need to coordinate it with your clinician. It just augments what's there. And we need to monitor how well it does, what kind of feedback is provided. The more we have the ability of the patient to link back in with the clinician, the less likely we're going to have a problem. As you said, it's never going to be perfect 100%. I think that's the wrong lens. I think we have to start looking at it. Is it much better than what we do today? And I think that it will be. Who's responsible? Well, it depends upon what goes wrong and exactly what we said. Particularly if it's going to be in some fashion, either FDA or CDC or someone else reviewed and approved, the chances of having a problem as an individual clinician is very low. If all we do is trust the tool, that can be problematic, but you're taking that same problem right now when you have your staff do the renewal. How do you know what's going on? Maybe there's a problem you're not aware of. This is where I think, again, not that there'll be no risk, but less risk than we have today. That's at least my hope. But what I do know is that hundreds of thousands of people die in the United States every year because we do such a poor job overall at a national level at managing chronic disease. None of us think that's what we do. Pull up the data and look at it. 55 to 60% for hypertension, less than 30% for diabetic control.
When I'm hearing you speaking, I'm hearing my little brother telling me how he bought a house without speaking to a human being. He got his mortgage and everything without speaking to a human being. And I thought that was it just seemed like it couldn't happen, but it happened. And you know what he said? The first point he made about being able to do it in this way, he said, I had the control, Faisel. He said, I had the control. When I'm hearing you speak, I'm seeing the faces of all the residents and all the doctors we meet out, in the last, before the pandemic, during the pandemic, now we're in the post-pandemic world. And when we meet doctors, now it feels like if they're saying 8 out of 10 American doctors, if we're reading 8 out of 10 American doctors are burnt out, it's probably an understatement. And the number one point that the doctors make is the loss of autonomy. And then when we hear the patient's frustrations, the patients say, gosh, I feel like I can't get access. The frustrations of the access has gotten worse. But here, when I'm hearing you speak, I'm hearing about getting the control back. And it makes me wonder, obviously getting control back for the patients is great for the patients. That's what they want. That's what we want as patients. Nobody chooses to become a patient. It happens. That happens to all of us, right? And the same thing goes with the doctors. But right now, there's a lot of money being made from all the inefficiencies. Little problems becoming bigger problems generate more RVUs. And so the culture, the people are ready. the players are ready, right? The players are ready, but the culture is still, I don't know if the culture is ready yet. Honestly, I don't even know if the people who are sitting deciding the models and what works and what doesn't work with, I don't even know if they even fully embrace that it's a lack of control issue here. And there are people who are profiting from this lack of control, both with the doctors and the patients.
The book, as you know, ChatGPT MD, has 5 parts. The first 3 are about the technology itself and the opportunities that it provides for chronic disease, for acute disease, for hospital at home, for inpatient care. We can discuss any and all of those if we would like. But the 4th part is on the problems: privacy, security, bias, misinformation. The last part, though, and the one I know that you've been focused on across your entire career, is leadership, because it's going to take leadership to make it happen. And why I say that, and you talk about autonomy and control, you can't have autonomy and control without responsibility. And to move there, we have to get out of the fee-for-service mindset, out of the transactional payments, to what you were able to accomplish in ChenMed, which is a form of prepayment, value-based care. I like capitation, a single payment to take care of a population of patients based upon how sick they are, with rewards coming when you can prevent heart attacks and strokes and cancer, with rewards coming when you make the right diagnosis the first time, rewards coming when you provide patient safety. And that is a little bit risky. And why is it a little bit risky? Because you have a risk, an economic risk, a financial risk. And when I look at, you said earlier about my first book, Mistreated, and then my second book, Uncaring. When Mistreated was written, I wrote about the problems in the healthcare system, the fragmentation, the fee-for-service methodology, the technology left over from the last century. And it wasn't my idea. I mean, you can trace it all the way back to 1932 for the CCMC, the Committee for the Control of Medical Costs. It was an idea that has been talked about and bandied about frequently. And yet after the book, outside of ChenMed, maybe little changed across the nation. And I said, well, it's got to be the culture. And I wrote Uncaring. And that also, I think, had a lot of very valid points and didn't have the influence that I wanted it to have, why I write books, why I give all the profits to Doctors Without Borders. But what I realized 2 years ago when generative AI came around is that the reason is that we haven't had a tool that would be reliable enough to be able for us to bet our future on it. Because once you are capitated, as you are in ChenMed, you make the decisions about what the patient needs. You decide what to do. You have that control. Now, you do it in a group context, so it's not necessarily every doctor for him or herself, but you're doing it being led by the clinicians that are there. And I want to make another point. This technology, generative AI, is doubling in power every year. When that happens for 5 years, it's now 32 times more powerful. That's like my telling you that 5 years from now, your car will go as fast as an airplane. Inconceivable to you. And yet that is what's happening. And I don't think we should be looking at what exists today. That's why I warn people, this is not yet ready for prime time. You still need to make your decisions in conjunction with a clinician. But it's coming, and it's coming fast. I was on a podcast earlier this week about the book. At the end of the show, the host said to me, Dr. Pearl, you're a skier, you're a physician. My husband fell 2 months ago. His arm was over his head. He slid down about 100 feet. And since that time, his shoulder keeps hurting, and he can't raise it very high. What's going on? And I said to her, I think I know exactly what's happening. Both of you guys probably know exactly what's happening. But why don't you put all the information into ChatGPT, which she had never used? And she wrote back to me a few days later, and she said, Dr. Pearl, this was amazing. First of all, it said he probably had a rotator cuff tear. It said he needed an MRI. It said most likely surgery was the treatment of choice, and that I should consult an orthopedic surgeon about that. And of course, the surgeon said it's exactly what he has after he got the MRI results, and said, had you waited a few more months, I might not have gotten the same positive outcome because the muscle might have contracted and I couldn't bring the tendon or the muscle belly itself as far as I needed to get that repair. It's why I speak about this technology as providing not just knowledge, but expertise. Google provides knowledge. Click on a link, you get information. ChatGPT generative AI provides expertise, and we have to decide whether we want patients who have more expertise or not. And my belief, and I know it's yours as well, is that the more the patient is knowledgeable when they come into the office, the better conversation we can have, The deeper the relationship we can build, and when they go home, the more likely they are to understand what we said and to be able to follow the recommendations.
Yeah, we're seeing it all the time now. We're seeing it now with the continuous glucose monitors that used to cost so much. Now there's coupons for, what is it, for like $67 now you can get a month for the continuous glucose monitor. I used to think that that was more for me than my patients, but it has been the exact opposite. It's been completely for the patients. Hey doc, oh my God, that waffle with the sugar-free syrup, it took my body 6 hours to recover from that. Oh, yeah. And and then it wasn't me dictating to the patient, hey, I need you can't go to Waffle House. You can't have that. Well, you can't, I don't care if it's sugar-free syrup. It's the patient telling me, boy, I gotta avoid the. So you're right. This suddenly a patient that we couldn't, it was like a wall for 5 years with, with the sugar-free syrup conversation. We've had this for many, we see our patients monthly, right? Now suddenly it was his idea. He's coming to me as an informed patient. So the tool was more for him than it was for me. What it gave me was the peace of mind that my patient was more informed. And that's what you're saying. This is what's going to happen.
Faisal, I love your story for the following reason. When I talk to clinicians, I often hear back, but my patient won't follow the advice I give them. And we haven't had the tool to help them. It's hard to do some of those things. And maybe the patients don't even necessarily believe everything we say. You've given a great example where a patient, once empowered, has a much higher chance of doing the things that is going to prevent the progression of their diabetes, the vascular, the neural outcomes that are likely to occur, and the complications that are going to result. Why would we not trust our patients? Already, they plan their trips on airplanes and hotels and sightseeing. They manage their finances, their bank account. They buy things online, figuring out how they can get it and return it. They do all these things, and they don't hesitate. No one has to make them do it. Why would we not think that if we can give them a tool to let them better understand their problems, to get answers and information, that they're not going to want to follow it? I'm not saying everyone, but a higher number. You'll probably still have some people going to that Waffle House and having the sugar-free syrup, but hopefully it'll be just a smaller percentage of your practice with fewer patients who need to get sent for dialysis.
You're providing feedback because when you think about most of the chronic conditions, whether it be high blood pressure, high cholesterol, diabetes, we're giving them drugs that don't make them feel better in the moment. In fact, often they feel they have some side effects from the drugs that we're asking them to take, and they're not getting feedback on how their condition's doing. So if you can engage them so that they're working on it, that could be really helpful. I have a pet peeve. I hate for people to talk about non-compliant patients, right? Patients are making the decisions to do what they think they need to do for them, and it's our job to help them make the right decisions. But at the end of the day, it is their decision. It's their life. It's not our decision, and they're compliant with what's been put in front of them. What do you think medical students and residents need to be learning to be able to use this? You might have said 10 years ago, well, they needed to learn how to code apps so they could do customized apps for their patients. But I think ChatGPT can do the coding for you now. So what would you advise a student today to be thinking about and learning about that will set them on the right trajectory to be able to take advantage of this in their career?
The most important part of generative AI, of general generative AI, and I do want to be very clear, maybe we should even dive a little deep into it, that we use the word AI. AI is just a generic term. You have to decide which type of AI you're talking about. There's rule-based AI where clinicians put in specific instructions. They're exactly like the algorithms that we use and learn in medical school and find in textbooks. They're good. They are shortcuts, but they can never be as good as the people who develop the algorithms, particularly because the people who develop them also have intuition to add on top of it. You then get to narrow. This is when you take 10,000 mammograms, 5,000 which show cancer, 5,000 of which don't. Either they're normal or have benign disease. And then the application using deep learning neural nets comes up with all the rules that exist. And out of that, may come up with 50 different slight differences, signs of probability factor to each. And it's able to read mammograms better than actually the majority of clinicians. The challenge with it, it's narrow. You spend a lot of time developing a narrow eye application for mammogram. It won't read chest x-rays or brain scans. There are 600 of these that have been developed and approved by the FDA. We'd probably need 50,000 to cover all the issues that arise in medicine. We're never going to get there. Generative AI is completely different. As you know, we download everything on the internet, all the textbooks, all the journal articles. It's been then given transforming information through parameters about how to analyze it. Something published recently is more valuable than something from the past. Something peer-reviewed is more valuable than something not peer-reviewed. Something from an academic institution or a large medical group like ChenMed is better than what a single doctor might publish on the internet. And then it uses that to be able to answer almost any question, which is why it is so effective, which is why I could answer that question for that host from the podcast who asked me about it. So that's the situation we have today with the generative AI that the previous applications were just simply not able to accomplish.
I look at where we are now. I'm so grateful that you got this, that you have this book out. I think that this conversation is not only great for those of us who are taking great risk with greater financial risk with our patients, but also for the doctors who are still, especially primary care doctors out in rural America, still living on, 2 to 5% margins, right? And the fee-for-service model, they're trying to figure out how to get there. This is a great way to help at least that mindset that, hey, you can take back control. You can focus more on the relationship. Let the technology focus on everything else.
Along those lines, let me go back to the question that Dr. Dan had posed about the medical student, which is the most important part of a generative AI tool application is the prompt that you give it. So when I wrote the book, ChatGPT MD, my co-author is ChatGPT. And I did that to learn from the process. I said, if I'm about to recommend people use it in medicine, the least I can do is use it in publishing. And so I had to first begin by downloading 1.2 million words that I had previously published so I could learn my voice and the way I like to write books. And then I went back and forth with prompts, maybe 200 per chapter. And it's the prompts that are the key. And you've got to learn how to use them. As an example, depending upon the information you put into your application, if you just say you're a patient with diabetes, it's going to give you one set of recommendations. If you say you're a patient with diabetes with this hemoglobin A1C, with this blood glucose, with this cardiovascular status, family history, my entire human genome, it's going to give you a much better answer that exists. If you ask ChatGPT, what would a 40-year-old white physician do? It's going to give you a biased answer because that's what happens in medicine today. If you asked it, what would a physician who wants to make sure that all the care provided is equitable and avoid bias do, it's going to give you a much better answer. It's the response to the questions that we pose to it. It doesn't work independently. And so I think that the main thing that medical students and all doctors, everyone listening should do is start using it. Start learning the prompts. When you see a patient, pretend you're the patient. Put all the information in place as though you had consulted ChatGPT before you see the physician. See what comes out. Learn from it. Try asking a next set of questions and a next set of questions. I actually believe that by the time 10 years have passed, that there'll be a course in generative AI and prompting and helping patients to use it. That'll be just as important as physical diagnosis has been as a core competency for first-year medical students.
Gone will be the days of the chief complaint, huh, Dr. Dan?
I mean, even when I was a medical student, I remember somebody telling me that 70% of the diagnosis comes from the history. Another 10 to 15% comes from the physical exam. And then the last 15% comes from all the millions of dollars we spend. And so to get the history, you need the right questions. And now what I'm hearing Dr. Pearl say is you need the right questions to get the right information to make. So you're not only questioning the patient, you're questioning AI, and you're having to go back and forth between the two to help the patient ask the AI the right questions. So yeah, that's pretty cool.
Well, Dr. Pearl, thank you so much for taking the time out to join us today to talk a little bit about your book, ChatGPT MD. Thank you so much.
My pleasure. And I encourage everyone, if you read it, let me know what you think. If you like it, that's great. But if you disagree, I want to hear that. Where is it wrong? Where are the problems that exist? And I do believe that if we're going to solve the problems of American medicine today, remember, it's estimated that medical costs are going to rise $3 trillion between now and 2031. What we know is that our life expectancy now is less than it was in 2010. 400,000 people dying from misdiagnosis, another 400,000 having permanent disability from misdiagnosis, 250,000 people dying from medical error. We have a lot of room to improve. So I think we need to be humble about what we're doing today. We need to be respectful because clinicians are working very hard. They're very dedicated. And we have to recognize that the gap isn't one about the people providing the care. You could say it's the system of care. I like to say it's the lack of the empowerment of the patient. And if we can bring the patient in a positive kind of way, if we can use it ourselves to be able to make the right diagnoses, I think we'll have an opportunity to, once again, make American medicine the best. You guys have led through ChenMed, trying to do it in the model. It's been a major success. I've tried to do it through the books that I've written and my time as CEO in Kaiser Permanente, but it hasn't scaled anywhere across the whole country. And what I'm hoping today is that generative AI, ChatGPT, will accomplish that. So please buy ChatGPT MD. All profits to Doctors Without Borders, a great charity. Thank you for having me today.
What are your thoughts on ChatGPT MD, AI-empowered medicine? You've heard ours. Now we want to hear yours.
And don't forget to mark your calendars because we're bringing the conversation to you live and direct.
Join us at the highly anticipated Primary Care 24 event on Wednesday, May 22nd, where we'll be hosting a special live recording of our podcast.
It's going to be an absolute blast, filled with insightful discussions and special guests.
Whether you're a healthcare professional, a policy wonk, or just someone who cares about the future of primary care, this event is for you.
So grab your headphones, your favorite beverage, and head over to primarycareforamerica.org/primarycare24, or just click on the link in the show notes to register for the event.
Don't miss out on this unique opportunity to be part of the conversation shaping the future of healthcare. See you there.
Register now at primarycareforamerica.org/primarycare24. Faisel and I can't wait to see you there.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.